Welcome back to LSP Symposium. At this session, I'm Dr. Raymond Yong, and my co-chair is Dr. Raymond Lee. Together, we will convene this session and introduce our four speakers for this morning. And our first speaker for this session is Dr. Boon Hong. Dr. Boon Hong now is the head of the Department of Anesthesiology and also the honorary consultant anesthesiologist at the Hong Kong Sanatorium and Hospital. Before joining us, Dr. Yong is the head of the anesthesiology team for liver transplant at Queen Mary Hospital, which is us. He has been bringing vast of experience to our hospital, and now is also the co-chair of the Anesthesia and Critical Care Committee of the Transplantation Society. Today, he's going to share with us the in and outside the operating theater. Dr. Yong, please.
Thank you, Mr. Chairman. In this short presentation, I will highlight some history, the current practice, and a brief look into the future of anesthesia in Hong Kong. Next slide. How do I advance the slides? Okay, thanks. Okay, at the turn of the 19th century, the type and extent of surgery was limited by four big problems, namely pain, sepsis, bleeding, and something called post-surgical shock. And when the Treaty of Nanjing was signed, and you remember that was in 1842, anesthesia was still unknown in the world. A few years later, by 1846, the solution to pain in surgery was demonstrated in Boston by Morton using ether anesthesia. News soon spread, and within 2 years, we have the first records of use of anesthesia at Siemens Hospital in Hong Kong. Siemens Hospital doesn't exist now, and on the site is where Rattanji Hospital sits. Soon after, the use of ether and chloroform anesthesia were recorded at the Government Civil Hospital, which is now become the Prince Philip Dental Hospital. Now, these are two photos of operating theaters with a gap of about 50 years, 40 years. And you can see that there's no anesthesia machine. And the anesthesia machine is this gadget here, which is called a Schimmelbusch mask. And ether and chloroform anesthesia were given by dripping drops of the agent onto the gumji on the mask. And this was essentially the way anesthesia was given for the next almost 100 years. What about spinal anesthesia? Searching through the online archives, I came across this paper on spinal anesthesia by no other than Dr. Lei Shifan. And he addressed the problem of hypotension after spinal anesthesia by using intrathecal caffeine with Nupacaine. His paper contained data for more than 500 patients, so spinal anesthesia must have been quite commonly used at that time. This paper was read at the joint meeting of the BMA and the Chinese Medical Association in 1925. We fast forward now to the Second World War, to 1941, Pearl Harbor. When I ask my students about Pearl Harbor, half of them don't know where Pearl Harbor is nor what happened there. It was an important milestone in the history and development of anesthesia because due to mismanaged anesthesia, the Yanks killed more of their own at Pearl Harbor than did the Japanese in their attack in 1941. This is a comment made by many historians. So what happened at Pearl Harbor? Ether was in short supply. There were few skilled anesthetists in service, and the hazards of tiopental anesthesia were unknown to military paramedics. Patients were hypovolemic, they were anemic, they were septic, and a normal dose of thiopentone given to patients in shock with a decreased volume of distribution would result in toxic plasma levels. We don't know really how many died from the effects of anesthesia, but it was a large number. And modern anesthesiology was born from lessons learned in the tragedies of war. Pearl Harbor served as a wake-up call, and immediately after the war, governments realized that doctors well-versed in applied physiology and pharmacology were needed as trained anesthetists. Training schemes started. Faculties of anesthetists were set up initially within the College of Surgeons, later as independent colleges. In 1948, the NHS recognized one of the first specialties recognized was anesthesia. In 1954, the Hong Kong government invited Dr. Zoltan Ladd to Hong Kong to train. Well, he was the first specialist anesthetist with responsibility for training. This picture shows Dr. Ladd and Dr. H.P.L. Osorio, who held training appointments in Hong Kong U. And Dr. Osorio had trained with Professor McIntosh at Oxford University. And when Professor McIntosh visited in 1959, Dr. Lei Xufen was their host, and he hosted them at his home, White Jade. Dr. Ladd continued to work for many years in Hong Kong, and even after his retirement, he used to come back to Hong Kong to attend meetings. That's how we got to know him at Queen Mary Hospital until he died in 2014 at the age of 98. He was a real gentleman. Two of the early anesthetists who worked in HKSH were Dr. Chow Po Seng and Dr. Yong Ming Hon. Dr. Chow is known to many of you because he continued to work as an anesthetist still a few years ago when he passed away. Dr. Yong Ming Hon was featured in the South China Morning Post last December because he's one of the two surviving veterans from the Second World War who served as volunteers in the Field Ambulance Corps. He should be about, I think he's 99 years old this year, almost as old as Hong Kong Sanatorium. The knowledge and skills acquired as an anesthetist are useful in many areas outside OT. Anesthetists serve as first responders in the trauma teams, particularly in airway management. ICUs developed after the Second World War from PACUs. Later on, non-surgical patients were also taken in. Acute pain management developed into pain medicine as a subspecialty. MACs and GA began to be used outside OT increasingly. And anesthetists undertook and published research in basic science as well as clinical medicine, and were early participants and leaders in simulator training. The earliest ICUs in Hong Kong were developed in Kong Wah Hospital and Grantham Hospital, followed by Queen Mary Hospital in 1970. The ICU service at Hong Kong Sanatorium started in the 70s and were upgraded and modernized several times. And the ICU at Prince of Wales Hospital was established in 1984 and was instrumental in initiation of accredited training. ICUs are not just about hardware. Doctors trained in intensive care were needed. The Hong Kong College of Anesthesiologists established a fellowship in intensive care, starting with 15 foundation fellows in 1996. Our physician colleagues in critical care medicine started about the same time. This development was timely because when SARS appeared a few years later in 2003, the ICU and CCM fellows were the ones taking care of the sickest SARS patients. Today, the two colleges run a joint curriculum in intensive care. Moving on, new technology such as ultrasound has revolutionized the practice of nerve blocks for regional anesthesia and pain medicine. On the left, you can see a nerve block being performed for a patient undergoing mastectomy, and this is now a standard technique for this operation. And on the right, you see one of our colleagues, Dr. Lei Cheng, was doing a trigger point injection under ultrasound guidance. Now to say a few words about monitored anesthesia care, or MAC. MAC is more than just sedation, but it includes preoperative assessment, managing intra-op derangements, and the focus is on maintenance of the airway with the skill and equipment needed to convert to a GA if it becomes necessary. On the right-hand side, you see a graph which shows that contrary to common belief, MAC does not have a lower risk than GA. This graph is from the ASA and shows data from more than 7,000 claims since 2006 from the ASA closed claim study. And although the ones undergoing MAC were older and sicker, you can see that permanent disability and death were in fact higher with MAC than GA. And this just emphasizes the need for skill and vigilance for patients to prevent this from happening. In this hospital, anesthetists provide MAC and GA if necessary in different locations, in the endoscopy suites, in the angiography rooms, various locations, in X-ray, MRI, the cath lab, CT-guided biopsies, and others. And monitoring at each location must be up to college standards. Medical equipment has undergone a digital revolution, including in anesthesia. The two photos here show how anesthesia machines have evolved over 50 years. On the left, you see an operating theater in Grantham Hospital, and this is called a Boyle's machine. Many of us who started training in the 80s have used this kind of machine. And on the right is what is currently used now in Hong Kong Sanatorium. This is from the eye theater, but in second floor also, the machines are progressively being replaced. The latest vaporizers, in fact, use injectors, just like high-performance cars. And the flow meters have now gone digital. In fact, if you look closely here, these bars here is the flow meter. There are no bobbins in the glass tube anymore. Earlier this morning, Dr. Wai Lam talked about advances in surgery. And as surgical techniques advance, anesthesia and anesthesia techniques have to develop in parallel to make this possible. These are two examples from HKSH, the implantation of LVAD in 2011, and the first liver transplantation that we did here in 2016. What about drugs? On the left is the famous taupentone, which we mentioned earlier. But in fact, this drug has a long and safe long safety record, provided it's used properly. This drug here is called propofol, and we often use this for MAC and also for anesthesia. Supposedly safe, but in fact, if you do not use it properly, some very famous people have been killed by it. So the axiom is it's not the drug that matters, but it's how it's used. The future is now. Advances in technology are already affecting anesthesiology practice. This was the theme of last year's Congress at the IARS, the International Anesthesia Research Society, which coincidentally this year also celebrates its centenary. And the highlights from this Congress are that advances in surgery require development of anesthesia techniques, robotic surgery, endovascular aneurysm repair, TAVIs. These have all been mentioned, and in fact, this photo shows the hybrid theater with a TAVI operation going on. So these are already happening in Hong Kong Sanatorium. But what it means is that sicker patients, the trend is that sicker patients will be undergoing less invasive techniques. But this means that selecting patients for safe anesthesia becomes even more crucial. Another highlight is the use of artificial intelligence and machine learning with big data. And with this, the two examples given here is the development of a COVID deterioration scale, which can identify who are those who go downhill and then need more support. And also, sometimes in some patients, after induction of anesthesia, they crash the blood pressure. So there are algorithms developed which can predict this. Remote monitoring, there's a system called the Haven system, which retrieves data in real time from electronic records. And amazingly, it can predict 40% of cardiac arrests and unplanned ICU admissions so that you can take action before it happens. So the future is now, or almost. Earlier on, Mr. Lee presented the proton beam therapy, which will be set up in the Eastern Medical Center. And some of these patients will need MAC or general anesthesia. And as Mr. Lee mentioned, it has to be very precise. On the left, this shows a treatment center in the UK with the anesthesia machine and the patient being anesthetized. On the right is a photo taken from last month, and we are now setting up the anesthesia flow and the equipment and how we're going to plan for anesthesia for the patients who are going to undergo who will come for proton beam therapy starting next year. Thank you. That's a very brief run through of more than 100 years of anesthesia.
Thank you, Dr. Yong, for the interesting presentation on the development of anesthesia in Hong Kong. I find it very, very interesting. But any comment and question from the floor and also from our audience? If not, we all know that the development of modern surgery depend on two major drivers. One is the development of anesthesia and also development of medical devices. Our following speaker, Dr. Stephen Wu, will introduce to us how the medical device can help us in the advance in the orthopedic surgery. Dr. Wu is the head of our orthopedic and traumatology department. His major interest in the strong promotion of precision surgery. He has been pioneer in introducing a lot of several new technology into Hong Kong and also into our hospital. Dr. Stephen Wu, please.
Thank you, Chairman. Good morning. The evolution from Young Nursing Home in 1922 to the present day HKSH Medical Group. It is a history of a successful survivor in the last century in this rapidly changing world. And I'd like to take this opportunity to congratulate our hospital for celebrating this 100th anniversary of the hospital. Orthopaedics in the last 100 years was born, developed, and became an established specialty. It went through 3 stages of development roughly. The first stage, which would be, we know the disease better. The second stage would be, we can start solving problems in the past. And the first stage, we can make our management better. For the first stage of the development, we find out causes of different diseases. It's interesting to think back that it takes humans centuries to find out causes of different diseases. Like sciatica, which is an Asian-old problem, it was not until 1932 that the first intentional discectomy was performed by Mixter and Barr. And in the last 50 years, many more diseases were described, like the list below, like the snap lesion in the shoulder. Radiology and development in other specialties play a very important role on this aspect. For the second stage of the development, I think that's the exciting part of being an orthopedic surgeon. We can start solving problems that cannot be managed in the past. One example would be traumatic amputation of the limb. In the past, with such a problem, as a doctor, I think the best we can just think of ways to close up the wound and fit a prosthesis for the patient. The first successful replantation of the forearm was reported by Chen Zhongwei in 1963 in China. And next year, Ronald Mount in US also reported his successful replantation done in 1962. Development in microsurgery has been very prosperous in those days, and I joined the wave of the development that I performed the first major limb replantation in 1988, 1 year after my fellowship examination. And the patient ended up with very good results. He got a sensei nip and can walk again independently. In 1995, another mid-neck amputations was replanted. And subsequently, the patient required 3 combined L dorsal and a serratus anterior muscle flap to resurface the wound. He can subsequently walk again independently, and he could even ride a bicycle. With discovery of the knowledge in vascular anatomy in the 70s to the 90s, come up with a lot of different flaps, and you make complicated reconstruction possible. Use your imagination. Difficult problems can be solved. Like this man with a sarcoma in the thumb. After wide excision of the tumor, end up with a big defect here. I employ a free vascularized fibrillar osteocutaneous fab to reconstruct the thumb, and he can use the thumb again. Technological advancement brought major improvement in orthopedics. In the last 19th century, fractured femur, take for example, carry a high mortality. And with the invention of the Thomas splint, it greatly reduced the mortality by the splint itself can help to spin the limb and stop the bleeding and allow painless transportation of the patient away from the field of injury. The evolution from a pin to a nail also changed the way how we treat fractured femur. Like in the early days, fractured femur was mainly treated with, like in this child, fractured femur was treated with a calcaneal pin. But the downside of this treatment is the patient have to stay in the bed for 2 to 3 months. 1940, in that year, Kuntscher, a German surgeon, invented steel nail, and he used the nail to treat fractured femur for the soldiers in World War II. And it was the prisoners of war that brought this nail back home, and its use was then known by the other countries. In the 1960s, the group in the AO group in Switzerland further refined the development of different implants for fractures. And with the evolution of the nail designs, femoral fracture of different complexity can mostly be managed with the current day intramedullary nail. We can even inject bone cement through the knocking bolt to enhance fixation in very osteoporotic bones. We also have intramedullary nail for many for other long bones like the humerus. Innovative ideas come up with different design like this school-in-school construct that helps to solve different problems. This lady with multiple myeloma, gross bony destruction, segmental fractures, very osteoporotic bone, it can be managed well with this intramedullary nail. Next slide, please. Same development happened with the screws and the plate. That nowadays we have bone or region-specific implants for almost every piece of the bone in the body. And in difficult cases, you can also employ the 3D printing technology nowadays in preparing patient-specific instrument and the implants. Like this young lady with distal femoral malunion, to tackle the problem, we employ the 3D printing technology, print out the bone model, perform the osteotomy before the operation in the bone model, simulate what should be done, and then the problem is solved. Other technological development, like the use of fiber optics, allows the use of development of knee arthroscopic surgery, and it opens up a new chapter of minimal invasive surgery in orthopedics. We are now in the era that we can make our management better. A typical example would be total knee arthroplasty. This operation became a very successful operation since the 80s. But then this is not a foolproof procedure. Even experienced surgeons can go wrong. The surgeons may implant the prosthesis in a non-satisfactory position. It's simply because the instruments we use are mainly based on the visual judgment of the surgeons, and our eyes can be wrong. It was during SARS in 2003 that this computer-assisted navigation system was introduced into Hong Kong. This is a real-time 3D image-guided technology that totally changed the way how we perform total knee arthroplasty. The system consists of 2 infrared cameras that can emit and receive infrared signals. And with the computer and the necessary software, during operation, next slide, please. During operation, we place static sensors into the patient's bone, and then with the pointer and the sensors here, it acts as a mobile sensor. As long as the sensors, next slide, please. As long as the sensors are within the visual field of the infrared camera, you can detect the tip of the pointer. And then the computer to measure the distance between the mobile and the static sensors. Next slide, please. And with that, the surgeons take multiple points on the patient's bone and come up with a bone model in the computer. And also with the navigation system, we can assess the soft tissue tension and perform the ligament balancing across the knee. This is the technology that cannot be achieved by the 3D printing. Next. And with the guidance of the system, we can perform perfectly aligned and well-balanced knee, and the results are good. Next slide, please. Another major step forward happened in 2012 that our hospital purchased the first real robotic system of joint replacement in Asia. Next. Next, please. Forward. No, forward, not backward. 向前呢？向前呢？向前。再前。再前。再前。Yes. This robotic system composed of the computer and the software, the navigation system we use, and also the robotic arm. Next. Next. On the 18th of June, 2012, Dr. Tan and I performed the first robotic partial knee arthroplasty in Asia. Next. And 6 years later, with upgrading of the system, we performed the first robotic total knee arthroplasty. Next. Going through the two very difficult years of 2019 and 2020, Dr. Goh Siu-Kei and I completed the 100th robotic total knee arthroplasty on the 22nd of October 2020. Next. In performing the robotic total knee arthroplasty, we need to have a CT scan of the knee before the operation, and then we can perform all the necessary measurements. Next. Intraoperatively, the surgeon would take multiple points on the patient's bone, on the surface of the patient's bone, and then we will synchronize the preoperative CT data with the anatomical landmarks of the bones intraoperatively. Next. We also use the navigation system to perform this, assess the soft tissue tension and perform the ligament balance. Next. For the bone cuts, it was cut by the robot, but under the surgeon's control and guided by the navigation system. With that, next. Like this gentleman with advanced osteoarthritis of the knee, significant fracturing contractures, he was wheelchair bound before the operation. Next. The X-ray shows advanced osteoarthritis of both knees. Next. And after the robotic total knee arthroplasty, he can walk again without aids. The results were excellent. Next. That's the X-ray showing good alignment after surgery. Next. In the same period, in 2018, we start using the SIGO system in our hospital and perform and use this for spinal surgery. This is another example of real-time 3D image guided surgery. In the spacious operation theater, we had the coordinated operation table, the mobile CT scanner. Next. And then we can perform pedicle screw fixation for all levels of the spine. Next. The mobile CT scanner can scan the spine at the interest level, and then we can have 3D images of the spine at that level. Next. With the navigation system, we can insert the pedicle screw under the navigation control. Next. We drill through the dorsal cortex of the spine, through the pedicle, into the vertebral body of the spine. Under the navigation control, we can look at the computer, the screen there, and then we know where's the tip of our drill. Next. Once done, we can put in temporary pins into the spine. We do the CT scan, check the position. Once it's good, next, then we can insert the screw under navigation control. Next. Like this gentleman with a road traffic accident, he sustained the transfracture of the L3 of the lumbar spine. Next. that in performing surgery, we perform the kyphoplasty of L3 and insert the pedicle screw fixation from L1 to L5 percutaneously. With the dream set up, we can perform this dream operation now. Next. And on the 7th of May this year, Dr. Goh and I and the team actually celebrate the 100th SICO case performed in our hospital. Next. With the current day technology, like mentioned by Dr. Yong, AI, machine learning, and many other things, I'm sure next that we are moving towards another stage of development in medicine, that hopefully we can treat diseases and make it not a suffering for human. Next. Thank you.
Thank you, Dr. Wu. Thank you once again for the interesting presentation and also bring us along the development of precision surgery in our hospital. Any comment and also a question from our audience here and also online? If not, can I pass the second half of our session to Dr. Raymond Lee?
Good morning, seniors and colleagues. I'm Dr. Raymond Lee. It's my honor to be able to introduce Dr. Walter Lee to give a talk on 100 years of dental service in Hong Kong. Dr. Lee is the head of Department of Dentistry for Hong Kong Sanatorium and Hospital since 1981. And he's a director of our hospital, founding member of the Hong Kong Society of Orthopaedics, and fellow of Hong Kong Academy of Medicine and fellow of College of Dental Surgeons of Hong Kong. Dr. Lee served as an honorary professor in the Department of Postgraduate Orthodontics in the Prince Philip Dental Hospital since 80s. So without ado, may I invite Dr. Lee to give a talk on the 100 years of dental service in Hong Kong. Dr. Lee, please.
Thank you. We need to review some historical data of dentistry of the world and then that of Hong Kong. By 1700, dentistry had become more defined as a profession. In the year 1723, a French surgeon, not a dentist now, Dr. Pierre Fauchard, was credited as the father of modern dentistry, published the book called Surgeon Dentist. The book defined a comprehensive system for caring for treating teeth, and the first dental professional that introduced the idea of dental fillings and the use of dental prosthesis, identifying that acids from sugar led to tooth decay. 1839, American Journal of Dental Science began publishing articles. 1840, the first dental college opened up, the Baltimore College of Dental Surgery in the United States. In 1842, Hong Kong became a British crown colony, and the population grew rapidly to about 33,000 in 1850s. More and more foreigners moved to Hong Kong, such that by 1870s, there were over 1,000 resident foreigners, and attracted by the local population's dental demands, Dr. Herbert Poet from the University of Pennsylvania set up the first formal dental practice in the early 1880s in Hong Kong. The post-noble dental practice gave free dental service at the Alice Memorial Hospital, where the College of Medicine of Hong Kong was established. And in the year 1901, Dr. Moon Hong Chuan became the first Chinese dentist, also a University of Pennsylvania alumnus, set up practice in Hong Kong. The first Hong Kong dental ordinance was established in June 5th, 1914, and practitioners in dentistry were categorized into two groups: the formally trained dental surgeons and the exempted practitioners. Now, this latter group of dental service providers were granted certificates of exemption by the governor in general, and there were 23 dental surgeons formally and 9 exempted persons practicing dentistry in May 1940. The registration of dentist ordinance was passed in 1940. Year 1859, 26 dentists met in Niagara Falls, New York, and formed the American Dental Association. 1867, the first university affiliated dental institution was established, the Harvard University Dental School. 1873, Colgate, for the first time in history, was mass-producing toothpaste, and a few years later started mass-producing toothbrushes. 1917, Irene Newman received the first dental hygiene license. Pivotal point for dentistry in Hong Kong was in 1981, with the establishment of the Hong Kong Dental School, known as the Prince Philip Dental Hospital. In 1981, in that same year, our hospital, Hong Kong Sanitarium Hospital, established the first dental department in a private hospital and commenced that year full dental service to the community. Up to today, the Hong Kong Sanitarium Hospital remains the only hospital in Hong Kong, private or public, that is staffed by dental specialists in all 8 disciplines in dentistry. We must pay tribute to the foresight of the late Dr. Li Shu-Pui, past medical superintendent of this hospital, who established the first dental department in private hospitals in Hong Kong. This is a rundown of our department staff as of today. There are 12 private hospitals in Hong Kong. Currently, 6 provide dental services. 3 provide after office hours dental emergency services. Dentistry as practiced in most towns, villages, and even in cities in the world, including Hong Kong, in the 80th, 90th, and the early 20th centuries in the world were by blacksmiths, non-professionals, barbers, amongst the few formally trained dentists. And basically, there was only one dental treatment with a lot of these doctors, and that would be dental extractions without anesthesia. Yuck. And that's not too long ago. That's in Europe, last century, in the villages. And that's in America, last century, without anesthesia. With the development of dental techniques, materials, and procedure, and as time passed, the practice of dentistry in many places in the world, Hong Kong included, was carried out by practitioner, quote, practitioner, passing on their trades and techniques to apprentices, hoxi, definitely not formally trained dentists. Prior to the Second World War in Hong Kong, anyone could practice dentistry when his character was vouched for by 2 JPs in Hong Kong. During the 50s, due to the government budget, Not seeing when a Hong Kong dental school could materialize, Hong Kong government set up a scholarship every year. 5 to 8 qualified students were sent to Singapore, UK, or other universities with dental training recognized by the Hong Kong Dental Council and come back to serve Hong Kong, contracted to serve for 5 years. And then they are free to do their own private practice. Essentially, by the early part of the 80s, dental service regulations in Hong Kong were still practically new to primitive. Around 1882, there were over 2,000 illegal dentists practicing in Hong Kong. Some of us might recall the dental clinic clusters in Kowloon City. And these illegal dentists practicing were never really governed. And that was not so long ago. That was only 60, 70 years ago. Some of you might remember that. That's Kowloon City before it was torn down. 2 decades ago, maybe. It is with pride to see the prestige of Hong Kong dentistry in the world. As of today, Hong Kong has hosted several times the Asian Pacific Dental Federation Conference and the 83rd and the 100th FDI World Dental Conference. Dentistry in Hong Kong during this century has advanced from an informal street side practice to a discipline that now serves the community by way of registered dental professionals. Hong Kong had been relying on supply of foreign trained dentists until the first batch of dental graduates in 1985. Today, our dental school in Hong Kong, sole provider of undergraduate training of dentistry, enroll about 50 students at first, became 73 students in the year 2016. And this academic year starting, they are admitting 80 dental students. In Hong Kong, we have, as of July this year, registered dentists 2,702. Registered specialists, dental specialists, 310. Hong Kong Dental Association was founded in 1959, formerly known as the Hong Kong Dental Society. In the international arena, the association is now a member of the FDI World Dental Federation and is one of the founder member association of the Asia Pacific Dental Federation. The Dental Council of Hong Kong, of course, is important, established under the Dentist Registration Ordinance, Law of Hong Kong, responsible for registration of dentists and their conducts, etc., etc. The Hong Kong Academy of Medicine was officially inaugurated, as our medical colleagues well aware, on December 9th, 1993, with 12 academy colleges and 2 faculties. And as mentioned, dentistry was one of the academy colleges. This was a landmark for dentistry in Hong Kong. All dental graduates who received the dental training outside of Hong Kong are required to pass a licensure examination before they are qualified to be registered with the Dental Council since the 60s. In the year 2015, due to demand, the Dental Council increased the frequency of licensure examination for non-locally trained dentists from once a year to twice a year to facilitate. things changed with effect of from April 1st, 1990. Holders of primary dental qualifications granted in Australia, Canada, US, and South Africa were required to pass dental council's licensure examination as a prerequisite. Previously, they were exempted. And 2 years down, October 1st, 1992, even holders of primary dental qualifications granted in UK, Ireland, Singapore, New Zealand, also required to take licensure examination before they can register and practice in Hong Kong. And as you can understand and appreciate, the foreign trained dentists practicing in Hong Kong percentage will be getting less and less. The University of Hong Kong's dentistry now has been ranked number 2 in the world, according to the latest QS World University Ranking as of September 2022. It marks the 5th time that Hong Kong University dentistry has been ranked among the top 2 globally, which so far no other institution in the world has achieved previously. First batch of 70 BDS students graduated 1985 on a 4-year 4-month course. First Master of Dental Surgery graduated 1986. First PhD dental candidates defended their thesis 1987 in Hong Kong. In early 1990, the BDS program was extended to 5 years. And in 1994, the BDS program gave undergraduate students the opportunity to spend 2 to 3 weeks at a dental school abroad in their year 5. In 1995, first batch of students reading the 5-year BDS program graduated. Year 2016, 2018, Faculty of Dentistry topped all dental schools in the world by world ranking. We must talk a little bit about the public dental service in Hong Kong. Services cover the cost of primary school students and civil servants only. The government provided 11 dental clinics amongst the 40 government dental clinics, which offered to the general public sessions that handle dental emergency services only, pain relief and extraction, and including medication, of course, free of charge. And we are talking about in these clinics, 1 morning session or 1 afternoon session in a week. The latest figures indicated that members of the public have to wait for 12 to 18 months for general examination at government dental clinics, and the waiting time for treatment for more complicated procedure like root canal can be 39 months. Now, Hong Kong has a very unique service, the school dental service. Primary dental healthcare program administered by the Department of Health for all primary school children. These children can go to one of the school dental clinics near their schools. The service is carried out by qualified dental therapists or trainee dental therapists. They are not dentists. They work under the supervision of dental surgeons, and they do only cleanings, simple fillings, and simple extractions. Now, looking into the future of dentistry, the quality of dental professionals in Hong Kong in the future have no doubt will be on par with top international standards. But the prospect of efficacy in providing this service, I should say, would be dismal, looking at how many dentists we have in Hong Kong. We definitely need more dental practitioners, more dental nurses, more hygienists, and more more dental technicians. In recent years, there have been weekly and monthly criticism from newspapers. However, there is a Chinese saying, 事在人為. In English, where there is a will, there is a way. And there's also a Chinese saying, 前人種樹，後人乘涼. Our forefathers planted the trees, we enjoy the shades. For the Hong Kong professional, for nurses, we're all enjoying the shades. I recognize some in the audience have helped out in seminars and give guidance to our dental school, especially the head and neck surgeons, the anesthetists, and the ENT surgeons. We are all building blocks of Hong Kong dental, Hong Kong medical, and that of our hospital, humbly in our own ways. We should all be grateful and be delighted for our mission in life, for our city, our home. Never are we to forget that we are also planting trees now, and will provide shades for the future generations of professionals to serve Hong Kong and the world. Thank you so much.
Thank you, Dr. Lee, for the very interesting talk. But for the limit of time, I'm sorry that we have to stop here. And may I ask Dr. KWOK to come to the stage? Dr. KWOK, as you all know, is a director of the Cardiology Center and Cardiac Catheterization and Intervention Center of our hospital since 2004. He is associate professor of the two universities in our location, and also the honorary professor of Beijing Hospital in China. He is a author and co-author of numerous scientific publications, including Circulation and Drama. He also actively participates in a major case conference in United States, Europe, and Asia Pacific region as international faculties, case operator, and speaker for over 20 years. So without further delay, may I invite Dr. KWOK to give his talk on interventional cardiology, our journey towards a new era. Dr. KWOK, please.
Good morning, Mr. Chairman, ladies and gentlemen. Thank you, Raymond, for your kind introduction. In the next 15 minutes, I would like to walk you through our journey in interventional cardiology. So nobody loves their chest being cut open. With the aging population, there is always a growing demand for complex and high-risk catheter-based interventional procedures, not only for coronary intervention, but also on non-coronary interventions. And we are facing a lot of complex lesions, left main, triple vessel disease, total occlusion, thrombus-laden lesions, and heavily calcified lesions, especially in elderly patients. Of course, intervention or bypass surgery are very useful in symptom relief in certain anatomical lesions. It also has prognostic indication, especially left main and multivessel disease. It's always reasonable to offer percutaneous or a more minimally invasive procedure versus bypass surgery in selected patients. This is a 90-year-old man with a left main and complex multivessel disease with a total occlusion of the LAD. I'm sure it's reasonable to offer a percutaneous procedure instead of a major operation for this elderly patient. Distal left main and totally occluded LAD, diffuse left circumflex lesion. The right is fortunate, is relatively normal with retrograde flow to the LAD. And we were able to open up the total occlusion and put in several stents. And this is the final angiogram showing pretty good result. And the patient is now 99 years old. Sometimes we have to respect the patient's choice as well. Of course, bypass surgery is the first choice for patients 65 with unstable angina and with critical distal left main like this, and also total occlusion of the LAD. But the patient refused surgery, and a percutaneous intervention is a good option. This is the right coronary artery showing the retrograde flow to the totally occluded LAD. And we managed to open up the total occlusion. And this is the final angiogram, which was pretty good. We extend the left main LAD and also the circumflex. So we always have options there. But for acute myocardial infarction or heart attack, of course, time is important, and primary angioplasty is the gold standard. And in this case, there's a plaque rupture in the RCA, and the patient got ST elevation. You can see on the EKG, and a lot of thrombus inside the coronary artery. We use a thrombus suction device. You can see the filling defects here and there. And this is a final angiogram, and these are the clots or thrombus that we aspirated out. And we have to do this in a timely manner. In this case, we managed to finish within 47 minutes. Calcified lesions, of course, is best picked up by intravascular imaging. We have a lot of advanced intravascular imaging. This is OCT, optical coherence tomography. We can define the depth of the calcification. Intravascular ultrasound, we can see the calcium, and would block the ultrasound energy behind the calcium. And nowadays, we've got newer tools that can help to crack the calcium to facilitate stenting. This is a shockwave intravascular lithotripsy. It's pretty much the same as the shockwave we use to treat renal stone. With this miniaturized device, there are emitters that can generate pulses that create short bursts of sonic pressure, which can crack the medial and intimal calcium for treating very resistant calcified lesions. And we were among the first batch of doctors who used this device, and we also reported the ventricular capture phenomenon in 2019. And this is the case where you can see the napkin ring appearance where the lesion failed to yield after a conventional cutting balloon. And with the shockwave, it easily cracked the lesion. Okay, you can see the balloon is now well expanded, and we also see the ventricular capture during the procedure. Sometimes we combine rotational nephrectomy with a shockwave with very resistant calcified lesion. You can see the long calcified lesion here, even under a fluoroscopy. And in this case, we use rotational nephrectomy. This is the intravascular ultrasound image after the rotational nephrectomy. You can see the typical Mickey Mouse sign. And after the rotational nephrectomy, we still found a lot of deep calcification. So we went on to use the shockwave and to crack all the calcium before we implant the stent and make sure the stent is well expanded. This is a final angiogram and very nicely expand the stent. Andrew Grunsit was the first man to perform the live angioplasty on a patient, and unfortunately he died in a plane crash at the age of 46, but his patient survived 30 years later. And he would not have imagined how the field has evolved to today. And we are not only doing coronary interventions, we're also doing transcatheter valvular interventions. And today, actually, we're celebrating 45 years of percutaneous coronary intervention and 20 years of TAVI worldwide. And over the years, we have witnessed the advancement of technology. We're now able to use 6 French and 5 French catheters, mostly transradial procedures. The patients felt much more comfortable, and it's a much safer procedure. And we have also seen the development of drug-eluting stents. We have better stent platforms and a lot of atherectomy devices, and also shockwave that can help. In the past, we used radiation brachytherapy to treat in-stent restenosis, but very soon we found that we don't need a nuclear weapon to treat a benign disease. We also saw the development of biodegradable stents. And over the past 18 years, we saw a significant growth in interventional procedures. Of course, there was some dip during the pandemic, and there was a rapid catch-up of transradial procedures, and it essentially replaced transfemoral procedures, and patients just left the cath lab with a tiny kosher device like this. The development of drug-eluting stents, we introduced the first drug-eluting stents 20 years ago. And it's a breakthrough because it reduced the restenosis rate down to single digits, but the first generation device did have the problem because they delay healing. This is the bare metal stent. You can see complete new healthy coverage by endothelium, but for drug-eluting stent, they actually delay the healing, and you can see the metals exposing to the circulation, and it necessitates the use of prolonged double antiplatelet agents. So any new technology would face critics, and critics against the drug-eluting stent after 4 years of use was fierce. But we cannot go back, because we cannot go back to the era where we have patients coming back and again for angioplasty. So there were a significant improvement in the platform. We have improved more biodegradable, biocompatible polymer. We have improved dosage of the drug and also thinner thread design. Nowadays, drug-eluting stents is standard of care for treating the whole spectrum of coronary artery disease, and it's actually completely replaced the bare metal stents. And you can see the healthy endothelium covering the current contemporary drug-eluting stents. Biodegradable stents, the concept was pretty good, all right? If you have a stent that would disappear after 2 years, it was perfect, because theoretically there would be no chronic inflammation, no late stent thrombosis, and the vessel would return its own vasomotor tone. We were very excited in the year 2012 when we first used the biodegradable stent. We were interviewed in San Francisco. We worked with physicians in Asia to work out the guidelines on how to select patients for the device, and also did all the technical considerations. Unfortunately, the first generation device was not that forgiving, because if you over-dilate, it would fracture. If you under-dilate, you have a significant malposition, which poses a threat of late stent thrombosis. So the first generation device was voluntarily recalled after 5 years of use, despite it's been FDA approved. And the real world, the learning curve was steep and painful. And we need very meticulous handling. And the current DS also is too good to exceed. With good case selection and good implantation technique, like this patient with a proximal LAD significant blockage, critical stenosis, we implanted biodegradable stent, and 4 years later, the CT scan was perfect. So case selection is always important. Perhaps we need more better platform with more radio strain, faster resorption time, and easier handling and low thrombosis rate. The magnesium stent is another choice. It's a metallic stent, but it would dissolve within 1 year, and has very low thrombosis rate and very low restenosis rate in the initial clinical studies. We implanted first in Asian Pacific region in 2016, and this is the OCT image. You can see that it's a metallic-like appearance inside the coronary artery. And this is a right coronary artery critical blockage. We place the McMurray stent here, and this is a 2-year CT follow-up showing nothing inside the coronary artery. So with good case selection, probably this is the future. And there is a new second generation BioMag magnesium resolvable stent device, probably will be available next year. So much so for coronary interventions, and big things have small beginnings. So we moved to non-coronary interventions. In the past, we mainly focused on valvuloplasty for rheumatic mitral stenosis patients or ASD, PDA occlusion. In recent years, we have moved to transcatheter aortic valve replacement and also mitral valve repair surgery. And all could be done through a small incision either in the femoral artery or femoral vein. This is a secundum atrial septal defect. This is a 4D TEE image. You can see the big defect here, and this is the ASD occluder. We inserted the device through the femoral vein, and the patient did not need any open heart surgery. And it contained a left atrial disc and right atrial disc, which just button up the defect. PDA is very rare encounter these days. This is an interesting case I did 2 years ago. 58-year-old with continuous murmur, and you can see the huge patent ductus arteriosus. Again, we can use a vascular plug to just close the PDA without surgery. For patients with atrial fibrillation and could not tolerate long-term anticoagulation, nowadays we can offer the option of left atrial appendage occluder to prevent future embolic stroke. Aortic stenosis is on the rise because of the aging population, and transcatheter aortic valve replacement, TAVI, is now one of the treatment options for these patients with severe calcified aortic stenosis. There are also other valves under investigation which we can use to treat aortic regurgitation as well. And the history of TAVI in Hong Kong started 10 years ago. And there was significant improvement in this device and also technique over the years, and making the procedure safer than before. This is a patient with dextrocardiacitis inversus, and we use this right subclavian approach. This is the TAVI device, and we are positioning the device over the aortic valve, and you can see the heart is actually located on the right side. And nowadays, we also use cerebral protection device. This is pretty much a gold standard now, containing of 2 filter, which can prevent debris from embolizing to the brain during the procedure. This is a self-expanding TAVI valve, And in this case, we use right subclavian approach. Our vascular surgeons create a graft and we just puncture the graft directly and advance the device over the graft to preserve the upper limb circulation during the procedure. Otherwise, the patient may go into upper limb ischemia. This is a standard transfemoral approach of another device. This is a balloon expandable TAVI. Again, we use the Sentinel cerebral protection device, and with a temporary placing, this is a standard procedure for the TAVI. Edge-to-edge repair for mitral regurgitation or tricuspid regurgitation is gaining more momentum in these years. It derived from the Alfari operation, which is a bow tie operation containing just suturing the tips of the mitral valve to reduce the mitral regurgitation. So this is the mitral clip procedure. We insert the catheter through the femoral vein. We did a standard transeptal puncture and straddle the device over the mitral valve. With the echo fusion technique and TEE, we can identify the site of severe regurgitation and implant the clips exactly where the regurgitation is the most severe. This is one of our patients with a rupture quality severe mitral regurgitation, as you can see on color Doppler. This is after putting in one single clip. There is a reduction of mitral regurgitation to almost zero. And in the future, we are looking forward to transcatheter mitral valve replacement instead of just putting in a clip. This is the future. All right, we have devices, again, transfemoral, venous approach, transeptal puncture. Of course, it's a very bulky device. There's still a lot of hurdles that we need to overcome, like left ventricular outflow tract obstruction, stabilization of the device. But this is the future. And we are stealing the job from our cardiac surgeon. Tricuspid valve is usually called the forgotten valve. In the past, with patients with severe tricuspid regurgitation didn't have much options. But nowadays, we can borrow the technique of mitral clip to TriClip. We can do TriClip for severe tricuspid regurgitation. We can implant a TAVI valve in the tricuspid position if they have an annuloplasty ring. We can use a cardioband for annuloplasty. For patients with a previous pacemaker or a very large gap, we can also put in a bicable valve. This is the TriClip device, pretty much similar to the MitraClip device. And this is the 4D-TE showing the positioning of the TriClip over the valve. But although we've got a lot of options at advanced technology, at the end of the day, we are facing patients. So in the future, of course, we have to, every care should be patient-centered. We have to respect the patient's value and preference and explain clearly the benefit and risk of each treatment option and have a shared decision-making. And heart team approach is the way to go. Is no longer a one-man decision. And cost medical inflation is a serious issue, and I would like to take this opportunity to thank Lee Ka-sing Foundation for donating 20 million to support our transcatheter cardiovascular intervention program for patients who could not afford the expensive consumables. And last but not least, of course, we need teamwork. And I would like to thank all my team members for their hard work throughout these years. Thank you very much for your attention.
Thank you, Dr. Kwok, for update to us the development of the interventional cardiology in the past and in the future. Before drawing the session to a close, may I please join me to thank our four speakers for giving the interesting and also the informative presentations.